Hey again, everyone. If you had just joined a second ago, I had a technical difficulty, but hopefully round 2 will go better. If you missed round 1, secondarily, I just want to say yay for Mike Eisenhardt, Hugs Not Drugs. And what I was about to get to was talking about some of the courses that ICE has coming up. If you are interested, in February there is a lot going on. There are a couple of different fitness athlete management courses that would be amazing to take. There's also the management of the persistent pain patient that is starting in February for the second cohort. Jump into any of those if you are interested. More stuff at ice.physio. Additionally, signing up for the virtual ICE program is open until January 8th. And that's a pretty amazing opportunity, so jump on that if you get a chance. Before we get started on our tips for treating acute MVAs, I also just want to apologize for my lounge singer voice. Hopefully some of you find that more entertaining than detracting. So I wanted to talk about MVAs this morning because I really believe this is a group of people that PTs need to get better at treating. As primary care providers, we are going to start seeing these people more acutely. As they know that we're the people that are going to treat them in the end, they're going to start skipping going to the doctor first, which I think is great because I don't think that that's always an important or necessary stop. But we need to start understanding how to treat these people if we're going to see them more often. But I also think that we are the best people to treat these folks because we are going to be the established provider that knows them. So as these people start knowing to come back to us, we're going to be that PT that knows what their body looks like, knows what it feels like, knows what their issues are going into this, so that when they have that MVA, that accident, we're going to understand what has changed just versus what they're telling us about, right? So it's good to have some perspective with people's bodies in that realm, and I think that's going to be really advantageous to us as we start treating these people more acutely. So during a car accident, I think the best thing to remember when you're seeing a patient is kind of talking about or thinking about the mechanism of injury, right? So when someone's in a car accident, their body was going a certain velocity, and then it changed velocity very quickly, which is the problem. So every part of their body went through some portion of a whiplash, went through some change in velocity where things accelerated, stopped really fast, hopefully, and then shot back, and then either their head hit their car, something else brought their body to a state of rest. Now, if you think of that, you've got, during that mechanism of injury, you basically have a sprain or a strain of the spine, the ligaments, tissue, the nervous system, more importantly. And so when you have that kind of an injury going on for all those different types of tissue, you're going to get a lot of guarding. Now, right after an MVA, a lot of patients, their first go-to is they want to go to the massage therapist, or they want to start stretching because they feel really tight. But the thing that I tell people is that rest is best and tape is great, but no massages, right? This is an important piece because people will go out and get massages or they'll stretch like crazy because they feel so tight, but it's only going to harm them. When you have a protective mechanism going on with the body, when you try to take it away, the body's going to do everything it can to fight back. And patients don't know that. They just know what they feel. So being able to educate them about those kind of mechanisms and tell them, hey, we're only a week after your accident, it's probably not late enough yet for you to get a massage, is important because they don't know these kinds of things, but people can end up with some pretty significant increase in symptoms, not only from getting just what they would consider a simple massage, but if they're stretching a tissue that's recently been damaged, and instead of allowing it to kind of just rest and stay in one place, then you can create a more chronic situation going on instead of a faster healing time. So these are people that we want to give them stuff like positions of comfort, help them to feel good, modify their ADLs, and make sure they're really getting enough rest. And it depends on how severe the accident is too, right? Two different people aren't necessarily both going to need to stop working, but for some people, they're going to need a rest of at least 3 to 4 days, maybe a couple weeks, depending on the severity of their symptoms, so they can just rest and relax and start that healing process. So really educating them that, short walks are going to be helpful if that's appropriate for your patient, or that taking a hot shower might be the thing they need instead of a massage can be super, super helpful. The next thing that all PTs really, really need to know if you're treating MVAs acutely are the Canadian C-spine rules. Now, whether you have a patient that comes in that, has some neck pain, or whether you have a patient that comes in with severe neck pain or no neck pain, if they've been in a car accident, it's important to really screen these out. And you should either have a sheet on the wall in your office or in the clinic rooms where you're going to be screening, or you can have it memorized in your brain. I know, imagine that. But you guys have to remember, if it was a dangerous mechanism of injury, like a severe car accident, if they're over 65, or if they have paresthesias into their extremities following the accident, you need to send them for an x-ray. And not just an x-ray, but one where they open their mouth, where I tell people if you need to be tasting the snowflakes in the room. Because if you don't get a good look at that C1, C2, you're not getting the information you necessarily need. Now from there, if all those answers are A+ okay, the next stage is more appropriately made for an ER, right? So it's, are they sitting in the ER? Are they able to hold their head up? But secondarily, and this is the one that I think is more key for clinicians to know, is was there midline pain after the accident, right? So you're thinking about not just lateral pain, which is more common, but was there pain down the center of their spine? That's an indication there's a fracture. So is having an immediate onset of pain and symptoms, not having a later onset. So if they were in the accident and they got out of their car and they were instantly overwhelmed by neck pain, that's a bad sign. You need to send those people for imaging right away just to clear. So if you've got all those things checked off your list and you're still on the bandwagon of treating them, the next thing you're going to check is their active rotation. This is not your hands on them yet, but you're just going to ask them to turn their head. If they can turn past 45 degrees one way but not the other, not 45 degrees both sides, then again, they need an x-ray. And not all of these questions are specific to always picking up an x-ray, or they must have a fracture, But at the same time, if you're going to screen out every fracture, you really don't want to miss these, you guys, because these are the patients that it's going to be dangerous doing manual therapy, doing exercise, doing other things that could provoke their symptoms instead of help heal them. So make sure you know your Canadian C-spine rules and use them. Even when it doesn't seem like this person has a fracture, just think through things and make sure to ask specific questions, because patients won't always report this kind of stuff in that detail. The next thing to think about if you're treating acute MVAs is you must do an appropriate neuroscreen. Now, this also means you must do a neuroscreen for patients who don't present with any outward neurosymptoms. And the reason why is this. A lot of patients who have had a car accident, who are slightly concussed, or who may be having a vertebral artery dissection in progression or that's occurring, are not necessarily going to have neuroscience right off the bat. They might feel just fine in some way, shape, and form and not report any of the dizziness or the vestibular stuff or the visual elements or any of the stuff that would normally cue us to do a neuroscan. However, if you don't do on day one and your patient develops a problem on treatment number 3, where's your baseline? You need to have that neuro baseline so that you know if their symptoms are changing, if they're changing for the better, or if they're changing for the worse. So again, super important. Do your DTRs, look for your upper motor neuron things, check your cranial nerves, do that sort of stuff, because if you know what it looks like day 1, then when you're into visit 4 and something's a little bit weird, you don't wonder if it was weird day 1, but you didn't check it because you're doing all this other stuff. So make that a normal part of your evaluation with that patient right off the bat so that you know when things are changing and if they're changing towards the positive or towards the I got to get them out of here or get them some different kind of care, right? So important to know that. And along that line, remember guys, even with a simple MVA, patients can get concussions. It's that whole quickly forwards, then dramatic stop, shift, quickly backwards kind of movement, that coupe, counter coupe, where the brain sloshes around in the head. Not awesome for the nervous system, we've come to find out. And the medical community is better at recognizing concussions from lower level injuries these days. Patients will be really, really reticent. I didn't hit my head. I'm fine. Like, that didn't happen to me. But if you have a patient come in who is hazy, who feels a little confused, who has that feeling of being off, even if they don't have a lot of the other concussive symptoms yet, educate them that they might have a concussion and get them on a good protocol. And by that, what I basically mean is a relative amount of rest paired with understanding that situations like the grocery store or big, overwhelming places with lots of people will be more taxing for them, and that they're going to need some rest right off the bat because they may or may not have had somewhat of a slight brain injury. People right after car accidents don't love hearing that they've had brain injuries, come to find out. But at the same time, it's really important to get those people on the right track. The other factor that they found really predicts who does and doesn't do well after concussions is stress level. So the more stressed a person is during their car accident or after their car accident, and the more stressed they are regarding their recovery, the worse they do. So we really want to make sure that we are there supporting these people, giving them information, getting them on the right track so that they can start to see some progress right away. Because some of these symptoms can really set in with patients and be much more difficult to address later on or as they've really settled into the nervous system to do that retraining. Also remembering that you've got like your trigeminal cervical nucleus involved in a lot of regions when people have cervical whiplash. So be sure you're checking those type of things and remembering that even if there's no fracture, there's no big issue you're seeing that should warrant an X-ray or an MRI or some other kind of treatment, a lot of these symptoms can come from the upper cervical spine, guys. So if you have a patient who's dizzy, who's got ringing in the ears, who's having some really weird vestibular symptom type of stuff, if you can affect that by treating their cervical spine, kudos, that's awesome, right? So we need to be able to hop on that, understand that all these things are related so that we can then educate our patients, treat our patients appropriately, and not allow them to just live in this zone where they're just not sure they're ever going to get better or that these symptoms are untreatable. And last but not least, you guys, with these MVA patients, it's really important to build an appropriate expectation. When a patient walks into your door and they were in a car accident 2 days ago, things aren't going well, so they came in to see you, their amazing orthopedic PT, they're going to expect mostly that it's going to take a minute and then they're going to get better. But when I say a minute, what I really mean is more like a couple weeks. Like, people don't really expect to be dealing with symptoms for much longer than that. But what we know is that MVAs take a lot longer to heal than we might want them to. They take longer than most orthopedic injuries that seem like they're of similar intensity or, severity. So patients don't necessarily know that it's going to be a while, but if you educate them right off the bat that they're going to get better, but this is going to be a process, that they're going to be doing PT, they're going to have to make some modifications right off the bat, but everything's going to be fine. That's important because, again, we want to keep that stress level low, especially if people have been concussed, even just slightly. But again, I think when you set that up where patients know that they're going to be doing some form of PT, some sort of modification in their life for a couple months, which is a more standard protocol, I would say, then they're more willing to kind of jump on board and they're going to be more understanding and less judgmental of their body and their symptoms, which is really hard after a car accident. If you're in any kind of fast-moving car accident or even slow, it's really jostling and it can cause a lot of stress and like PTSD type of stuff. So imagine that you need a little bit more stability, like a framework. So we're going to give these people a framework, some way, shape, and form that they can understand how long it's going to be for their body so they have appropriate expectations. So guys, if you're seeing car accidents right off the bat, just remember, rule out fractures, do a neuroscreen, rest is best, tape is great. So you're not going to have them stretching, moving, exercising right off the bat, but you're going to save some of that stuff till their body and their irritability is more able to handle it. And then remember, you can have some of those weird upper cervical symptoms that can seem a little bit fuzzy with concussion type symptoms and other stuff. So we're going to make sure that we keep an eye on that and treat when appropriate. But remember, guys, go slow with these patients because acute MVAs need mostly rest. They've had a quick stretch, a strain of everything, including their nervous system, and their body is protecting it. So we don't want to take that away. All right, guys, hope you have a fabulous Tuesday. Happy New Year, and bon voyage.